Hello, my name is Amir Harb, and I'm a PGY2 internal medicine resident at AdventHealth Orlando, and I will be presenting an unusual case of anomalous left coronary artery from the pulmonary artery presenting as pulmonary hypertension. Introduction. Anomalous left coronary artery from the pulmonary artery, also known as Al-Kappa, is a rare congenital abnormality, and it typically presents in infancy and carries a high risk of mortality if left untreated. Survival into adulthood is uncommon and misdiagnosis is frequent, particularly when the symptoms overlap with etiologies such as pulmonary hypertension or cardiomyopathy. Case presentation. A 24-year-old woman with a prior diagnosis of pulmonary arterial hypertension on dual therapy presented with progressive dyspnea, syncope, and exertional desaturation. An echocardiogram revealed a left ventricular ejection fraction of 45% with severe left atrial and ventricular enlargement. Cardiac MRI showed subendocardial infarction of the inferior wall extending from the basal ring to the mid-chamber, involving approximately 40% of the myocardial thickness. A subsequent left heart cath showed that the left main coronary artery originated from the pulmonary artery with an additional left coronary artery originating from the right coronary cusp. Management and follow-up. She subsequently underwent surgical coronary reimplantation. At follow-up, she reported marked functional improvement, and a 6-minute walk test revealed that she was able to ambulate for 130 meters without experiencing desaturation. A repeat transthoracic echocardiogram revealed a left ventricular ejection fraction recovery to 55% and improvement in functional class from 4 to 2. As you can see from the imaging data panel in the middle of the poster, transthoracic echocardiography table, on the bottom panel where it reads right ventricular systolic pressure, the peak around the intraoperative period was 77 millimeters of mercury, which improved to 47 millimeters mercury about 3 years post-operative. And in the right heart catheterization table, about 2 years prior to the coronary reimplantation, her pulmonary artery pressure mean was around 53, and it improved to 32 millimeters of mercury about 1 year in the postoperative period. And as you can see in the bottommost panel of the right heart catheterization table, her medications 2 years prior to the reimplantation was sildenafil 20 milligrams BID, which were not controlling her symptoms. And about 1 year post-operative, she was able to control her symptoms with carvedilol controlled release 20 milligrams once daily. Discussion and conclusion. Al-Kappa is typically diagnosed in infancy, and patients rarely survive into adulthood without correction. The diagnosis requires left heart cath, which is often deferred in young women with presumed pulmonary arterial hypertension. Its misclassification as idiopathic PAH in this case highlights the importance of a full diagnostic evaluation in these types of patient populations. In this case, a low ventricular ejection fraction and a marked left atrial enlargement raised suspicion for left heart disease. Coronary abnormalities may masquerade as PAH in young adults, and this may delay recognition. A careful assessment for left-sided pathology in patients with unexplained pulmonary arterial hypertension is essential to avoid misdiagnosis and allow timely surgical intervention.